Ai rea te one tapu kahura tangata uta te tūraki atu ki tangata tai, kahura tangata tai te tūraki atu ki tangata uta. Pērā hoki rā te kōrepe nui, te kōrepe roa, te wāhi awa, te toitoi awa, whakamau wā tamaki te ara, whakamoe tamaki te ara no tū norongo, whanno, hara mai te toki. Haumi e, hui e, tāi ki e. Ko te wehi tuatahi ki te wāhi ngaro, te tīmatanga te whakaotinga o ngā mea katoa. A koutou rā te kāhui wairua, ko me nā tūraki te pō, haere whakangaro atu rā. Ke mai no rā ngā rārangi kōrero ki a tātou e pai nei, nau mai, haere mai, piki mai whakatau mai ki tō tātou whare kōrero, ki te poho, o ene āhuaranga, nau mai, whakatau mai. Welcome everyone and thank you for joining us today for our webinar, See Me Smile, Oral Health for Tamariki and their Whānau. My name is Kawati Waitford and it's a pleasure to welcome you on behalf of our team today. Today's webinar is hosted by A Better Start National Science Challenge and Whānau Āwhina Plunket. A Better Start National Science Challenge is a national collaborative research program working to help children achieve the best possible start in life. Its mission is to find practical, evidence-based solutions that make a measurable difference for tamariki, specifically in the areas of healthy weight, successful learning, and mental health and resilience. Whānau Āwhina Plunket is a charity and Aotearoa's largest support service for health and well-being of our tamariki under 5 and their whānau. It offers free Plunket nurse visits, a free 24-hour Plunket line, along with parent groups, education courses, playgroups, and more. Today, you'll hear from 3 top health researchers and experts about the current state of children's health, oral health in NZ, what initiatives the Ministry of Education is undertaking, and how oral health can be addressed in a whānau setting. So before we start our webinar, a little housekeeping. Today's webinar is scheduled for 1 hour, including Q&A. The webinar will be recorded and loaded onto our websites, so you can listen again later or share with others. All audience members will be automatically muted throughout the session, and there'll be a Q&A session at the end of the webinar today, so please submit your questions using the Q&A function located at the bottom of your Zoom window, not the chat box as we were probably used to using, and feel free to upvote questions submitted by others, and our team will field those questions to the speakers. Our chairs today are Professor Barry Taylor, Deputy Director of A Better Start National Science Challenge, and Dr. Paul Watson, Registered Nurse with Whānau Āwhina Plunket. Ia ku rangatira tēnā korua, and I hand it over to you. Kia ora.
Good morning and welcome to you all. It's been a terrible week, I guess, especially for people in Nelson, but we've got a fascinating webinar today. Oral health is really important. I was going to say it was a window into the soul, but it's actually a window into our health system in many ways, and we're lucky that within that area, we've actually got quite a few things by which we can measure how well we're doing. And our first speaker, Professor Jonathan Broadbent, is going to start off showing us some of the epidemiology and some of the figures around oral health in New Zealand. This is important because oral health not only reflects a range of other health conditions, it also has consequences for later on in life. And in fact, if we just think back to our own childhood, if you're brought up in my era, you will have lots of memories of going to the dentist as not being a great occasion, but also pain from, I guess, cavities. This should not be so for the current generation of children, and if our systems are working well, we will see really excellent oral health, and we're going to hear both from the epidemiology, from some policy issues from the Ministry of Health, and I'll introduce Riana later, and then hear a bit more about the individual delivery of oral health care for individual children, and some recent advances in that area from Alison Meldrum, who I'll also introduce later. So first of all, let's get the big picture. Jonathan, I've known since he was a knee-high to a grasshopper, coming into the offices of the pediatric department in Dunedin, where I work and have worked most of my life. And I've watched him grow from student through to staff member of the University of Otago, and then more recently attaining full professorship, which is hard to get and well-deserved. So, Jonathan, it's with great pleasure that I ask you to give us the first bit of information about oral health in New Zealand children.
Thank you very much, Barry, for that kind introduction, and tēnā koutou, hello to the audience. So I'm a dentist and dental epidemiologist. I work at the University of Otago as an academic here, and I'm very interested in longitudinal health, so health throughout the life course. And so if I, for today's session, I'm going to talk with you about oral health epidemiology among New Zealand children, but I feel like I can't do so without talking about what happens throughout life, understanding a little bit about the importance of oral health as a child for its implications for future trajectories throughout life. So a couple of terms here, DMFT, it's the count of decayed, missing and filled baby teeth. The small case letters tell you that it's baby teeth. And a trajectory is a pattern over time. So a couple of terms that you might see me use. Now, something I've done here is put together the available data for oral health at age 5 as a count of decayed, missing and filled teeth. This is at age 5 using data from the national level and also from selected regions of New Zealand. And something you might note is that decay levels have come down considerably from what they once were. Back in the 1950s, the average 5-year-old had about 7 teeth decayed. Now in the 1950s, New Zealand introduced in-office fluoride treatments, so that's something that could be done at the oral health, the dental therapist, or at the dental clinic. And community water fluoridation began spreading to certain parts of the country in the 60s. And fluoride toothpastes became fairly ubiquitous from the 1970s onwards. Now you'll see here that the figures look like they're sitting around fairly static there now. Some regions are worse off than other regions. And if we take this here for plotted in another way, so what I've done here is I've taken Caries prevalence. So Caries prevalence, the percentage of people who have decay. And on the other axis, I've put the count of decayed, missing and filled teeth. And so in that blue line, what you see there is the average number of decayed, missing, filled teeth for the entire population. And that dropped through to the 70s, and now you'll see you see in the 80s and 90s and through to today, there's a cluster of figures all close to one another. So nowadays, nation as a whole, about 40%, 40-something percent of children have experienced dental caries. And the average number of teeth decayed is about 2 in the whole population. However, among those with caries, it's about 4 or 5 teeth affected by caries among those with tooth decay. And that's an important distinction that I want you to be aware of, because there is a tyranny of averages hidden in average statistics. It looks fantastic in one respect that, compared with what things were at one point in the past, we've largely solved a lot of dental caries problems. However, that's not so for all sectors of the population. So children with severe caries, and this is one of our measures of severe caries, is children being admitted for a dental GA. And there's a couple of previous reports about this, the proportion of the number of admissions for dental GAs and also the disparities in this. So something that I've done more recently with one of my students is looked at one specific region of New Zealand. This is just one region of New Zealand. And we've looked at the population rate per 1,000 children of children requiring a general anaesthetic. And so you'll see here that the proportion of the rate per 1,000 European children has been low for a long time and remains low. However, for Pacific children, the rate is much higher. Now, this is for children aged 0 to 4, and it looks like the rates are coming down slightly. On the other hand, here we have the same thing for children aged 5 to 9, going up slightly over time. And so this is the number of children per 1,000 of that particular ethnicity in this region of New Zealand attending for a general anaesthetic treatment. Now, among those, when they do attend, another thing to be aware of is what's happening when they are attending for care. And this is the average number of teeth extracted per child. And that looks like it's a little bit on the rise there, that at a given visit, the number of teeth extracted is rising. So we've got the highest rate among Pacific and Māori Asian children, and those of Middle Eastern, Latin American, and African descent. So now I'm going to talk very briefly about sort of a little bit about why I see this mattering. And so 2 New Zealand longitudinal birth cohort studies, the Dunedin study and the Christchurch study. Both of these studies collected clinical dental data when study members were aged 5, and we've also got adult general health data from these studies. And this is something that we've repackaged this information here. This is just showing that social gradient in both of those studies. There's a social gradient for dental caries experience at age 5, both in the percentage of children with decay and how bad that decay is. And you can see here how this relates. These 2 data points are from the Dunedin cohort and the Christchurch cohort. And you can see where they fit very close to the children of today. But in both of these studies, children who had childhood caries experience ended up having worse oral health related quality of life. Worse self-rated general health as adults. They're less likely to have excellent self-rated general health as adults if they had had dental caries at the age of 5. We also find the same sort of thing with future rates of tooth decay. Tooth decay at age 5 is associated with the rate of tooth decay as an adult. This is a slightly complicated graph, which I'm not going to go into in full detail, but there are inequalities in disease levels and inequalities in treatment. The 3 rows that you'll see here, the top row is untreated tooth decay, then the number of fillings that people have had, and the number of teeth that have been lost. And some of the biggest determinants of this are social determinants and early childhood caries experience. So I've nearly finished my little piece here, but I've been doing some work with another New Zealand cohort, with one of my students and some colleagues from AUT looking at the Pacific Island Family Study. And that study is very interesting because they have some fantastic toothbrushing data from the early years of life. And we're able to identify that about 22% of children from that study brushed their teeth twice a day consistently across all of these years. And that's what we want people to be doing. But there were unfavorable toothbrushing trajectories. Those who brushed twice a day and then stopped doing so by age 9, those who weren't doing so and then had taken that up by the age of 9, and the ones who were inconsistent throughout childhood with their toothbrushing behaviors. And among other things we found, being male is a risk factor for having an unfavorable toothbrushing trajectory, not owning a home, low frequency of parental brushing, but most noteworthy, economizing on food and having to spend less money on food due to financial challenges. And it's very interesting to see that economizing on food sort of matched with how people were brushing their teeth. Toothpaste and toothbrushes are at present a supermarket commodity, and people who have financial struggles likely that's perhaps one of the first things to not go in the supermarket trolley because you can't eat toothpaste. It's got no nutritional value and it is relatively expensive. So any steps to eliminate financial barriers to toothbrushing, I think is a good thing. So this is my last slide here. For anyone who's interested further, I'm a scientific editor for the New Zealand Dental Journal, and here's a couple of papers we recently published in the New Zealand Dental Journal on childhood caries, risk factors and preventive strategies. A couple of colleagues wrote these papers, and another paper by myself there on investing in prevention to improve child oral health in the long term. Strategies like sugar regulation, removing financial barriers to toothbrushing, steps to improve oral health literacy, ways to improve the oral health of mothers. You can't do it without the intergenerational approach, and considering common risk factor approach, oral health promotion in all settings when we have such a high proportion of children affected by decay, not just at the dentist. So thank you very much.
Jonathan, thank you very much for that. It gives us an overview of where we've come from and where we are right now, and some of the important both individual and perhaps public health factors that we need to keep our eye on. Dr. Riana Clarke is the National Clinical Director Oral Health with the Te Whātu Ora, and she works she's actually been in New Zealand about 18 years. And has come from Ireland and the UK, as well as the United Arab Emirates before coming to New Zealand. I first met her when I was briefly working with the Ministry of Health, and she demonstrated in a few meetings we had her passion for actually doing something really useful in terms of some of the individual practices in particular that we've just heard Jonathan mention. So it's a great pleasure to ask her to actually talk about the current programs that are being rolled out, and then we'll go on to the next phase. So thank you, Riana.
Kia ora koutou katoa, ko Nefin te moanga, ko Deal te awa, ko Atlantic te moana, ko Ngāti Airihi te iwi, ko Clark te tangata, ko Riana aho. Thanks very much for inviting me here today. Lovely to be here, and as Barry says, I'm very passionate about this. So, you know, if I get a bit carried away, apologies in advance. I'd particularly like to talk to you today about a strategy that was originally developed in the Ministry of Health, and that is now, because it's an operational matter at this stage, it has moved across to Te Whātu Ora, and I'm very fortunate to be able to work across both so that I can keep, it was kind of like letting go of a baby. I didn't want to, so I was glad to be able to keep a hold of it. So our National Oral Health Promotion Campaign, many of you are already involved in this and distributing product. So I'd like to just give you a little rundown on where it's come from and a little bit more about it. So we'll talk about that, why we need it. Obviously, Jonathan's just told us a bit about that. Why fluoride is important, data on toothbrushing, why did we choose Well-Child Tamariki Ora program to help distribute the product, what provider support resources are available, the product distribution and the evaluation of this initiative. So we have a national oral health strategy called Good Oral Health for All for Life, which was developed a good while back in 2006. And sometimes people say, could we update that, please? And my answer is, well, we could, but actually there's some really good actions in there that we'd probably put in again if we did a new one. One of them is promote oral health. Another one is about extending community water fluoridation, for example, which we're working on. And another one is about developing an electronic oral health record. But this one today is pertinent to what I'm talking about, promote oral health. So what happened was, as a result of the strategy, some money was given to the ministry to do some oral health promotion. So it was really important to do the research on where would be the best bang for buck. And there were discussions before my time on whether it should go towards, you know, improving adolescent oral health or child oral health. And of course, it was realized that there should be a focus on preschoolers. And also it made sense to include the Whānau. And it was decided that distribution of free toothbrushes and fluoride toothpaste, along with a social marketing campaign, was the way to go. And because, as Jonathan has pointed out, we have significant inequity in our oral health outcomes, the priority population for this initiative has to be our Māori, Pacific and low-income Whānau. So the social marketing campaign ran for a while. We did about 4 tranches of that over a number of years. And some of you might remember our tooth fairy flying across the screen and having a little word, a stern word with a dad saying, you know, you need to brush your child's teeth better. And that was evaluated by Te Heringa Hauora, formerly Health Promotion Agency. And it was shown to be very successful in that people who had watched it made changes to oral health behaviours in their home afterwards, with most of them, about 31%, saying that they had increased the amount of toothbrushing that they were doing for their children. And this also forms part of the child and youth wellbeing strategy. And the reason I have the picture of Jacinda Ardern here is because the Prime Minister, with her Minister for Child Poverty hat on, is a big fan of this initiative, and actually, you know, basically gave us the tick in the box to get the money going, to get the distribution going. And I think some of that was to do with having her own daughter and having experience of some sort of a connection with the services. So the key messages of the campaign that we had were that baby teeth are important and necessary for the health of permanent teeth. Under 5s need to have their teeth brushed by an adult, and that baby teeth should be brushed twice a day with a fluoride toothpaste. And I'm sorry, I'm going to just repeat a little bit of what Jonathan said because it's important. If we're looking at 5-year-olds and how many of them are decay-free, if we look at the total, we have almost 60% of 5-year-olds starting school with no decay. Woohoo, that's fantastic. Until you look down closer into the stats, and we see that actually only 40% of Maori tamariki are starting school with no decay at all, and even more specific are about 31%. And if we separate out then the non-Maori, non-Pacific, the other people, we're looking at, you know, coming up to 70%. So it's not equitable. And back to Jonathan's friend DMFT, so decayed, missing and filled teeth at age 5. Looking at the stats from 2005 to 20, you know, we haven't made massive significant differences in that, but what we see as the starkest thing we can see here is that we have much worse oral health outcomes for Maori and Pacific children compared to other children. And the hospital events Jonathan mentioned, so, you know, roughly just over 8,000 kids go into hospital every year for dental treatment, and about 84% of those events are for preventable conditions, mostly dental decay. And we can see that it's not fair again, because we've got 40% of those children are Maori children and about 18% are Pacific children in 2021. So yeah, Jonathan mentioned, if we're preventing decay, the things that we need to look at are social determinants, healthy food environments, community water fluoridation, toothbrushing with fluoride toothpaste, and regular visits to oral health services. And you know, we have just over half our population receiving community water fluoridation at the moment, and we've just before he left, Ashley Bloomfield directed 14 councils to start adding fluoride to their water, to start increasing the amount of fluoride in the water, because that's really, really going to make a big difference for a lot of people. The fluoride, just to say why that's important, is because it strengthens the teeth both as they're forming in the gums, but also very importantly afterwards on the surfaces while they're in the person's mouth. And so it strengthens the enamel, and the best way to have it is low doses regularly, a lot of the time. So that's why water fluoridation is really effective, and people don't have to actually really do anything to have the benefits of that. Toothbrushing is also really important, and the fluoride replaces any minerals that are lost on the surface of the teeth as the teeth are demineralized by having acids against them. And our, you know, the good places for us to get fluoride from are fluoridated water and fluoridated toothpaste. And what we recommend is that toothpaste has to have at least 1,000 parts per million of fluoride. So we did used to have some products on sale in New Zealand that were below that at about 500 parts per million. And actually the companies have very kindly withdrawn all of those low fluoride products. So now what we have on the shelves will either be no fluoride products or fluoride at the right amount products, which is much more helpful for people. And we recommend that you put, we were using the word smear, but in this campaign, unfortunately, the word smear had already been snapped up for another campaign in the Ministry of Health to do with smear testing. So we weren't allowed to use the word smear anymore for this one. So we changed to half pea sized. So for children who are under 5, the amount of toothpaste on the brush is the size of half a pea. And for those older children and for adults, it's a pea-sized amount. A dental professional can apply fluoride also. That's a different way to get, a different vehicle to get fluoride in the mouth. The New Zealand Health Survey is undertaken every year by the Ministry of Health. And in 2020, 2021, one of the questions asked is, do you brush your teeth twice a day with a standard strength toothpaste? And they're shown pictures of toothpaste so they can make sure they're using the right toothpaste. And we can see that about nearly 59% of children aged 0 to 14 are brushing their teeth. But if we break that down and look at the 0 to 4-year-olds, which of course is the group we're talking about really today, we can see that it's only 40% of children are brushing their teeth twice a day, according to that survey. So the goals of the initiative, of course, are to improve the oral health of tamariki and to promote attendance at the community oral health service. And on the right here, you can see we have some collateral that we deliver with the distribution. There's magnets and stickers and bags and things, but basically they're the 5 messages that Whānau will need. Brushing the teeth morning and night. Children under 5 need an adult involved. The half pea-sized and the pea-sized. Spit, don't rinse after you brush your teeth, and go and get your free dental care that's available. Why did we pick WCTO? Well, first of all, WCTO already has an oral health component at the visits at those ages from the 5 to 7 month check onwards. So the providers were already providing oral health information and advice. And so it was a no-brainer for them to be able to give out free product at the same time at those core checks. And the providers are very well versed in delivering oral health messages and giving diet advice. And also the Prime Minister was very keen, after having brought Niamh to her WCTO visit, that that would be a place where people could get free product from. And why are we giving product to the whole Whānau? Well, evidence suggests that toothbrushing behaviours of young children is strongly influenced by those of their Whānau. And of course, we know that targeting mums is really influential on child oral health, because the mum will have improved knowledge and behaviour, and both during and after pregnancy. And this will have benefits for the children and any other household members, actually. And so this resource is to lead to good Whānau toothbrushing practices in the home, particularly, is what our goal is. And we've all heard that story about the family who either have no toothbrush and toothpaste, as Jonathan said, because it was a case of, will we buy a loaf of bread or will we buy toothpaste? And the bread won out. And the other story we often hear is about the family who have one toothbrush shared among several of them, which of course is not ideal either. So we have a really good resource that hopefully many of you are aware of. This was originally developed particularly for Well Child Tamariki Ora providers between Ministry of Health and New Zealand Dental Association. And this is, you can link through to it from the New Zealand Dental Association website. And there are a number of modules in there, which includes things like lift the lip screening and explaining how dental caries, dental decay happens, etc. It was recently updated so that it will be applicable to people who haven't got as much of an oral health training like Well Child Tamariki Ora providers, because we have other providers distributing product as well. And there is a plan to update this even further this year with some new videos on toothbrushing, the appropriate ways to toothbrush for children. So the distribution of the product started in December last year, and we already have about 97% of the, let's call them the DHB Well Child Tamariki Ora providers on board. They kind of were our starting point. And then from the 1st of July, Āwhina Plunket came on board with us, having run a pilot in Wellington for a couple of months beforehand, just to make sure we had everything ironed out before, we suddenly had a massive request for product. We are seeing universal delivery through Welsh tamariki at the 5 to 7 month check, and then more targeted distribution of product at the 9 to 12 and 15 to 18 month checks, with the targets at those visits being Māori, Pacifica and low income preschoolers and their whānau. We now also have about 37 Māori and Pacifica health providers. We have some family start providers, immunisation, outreach and others also on board distributing product. And we have plans to include Kohanga Reo and Pacific language learning nests in time. We have a distributor that we pay to distribute the product to the providers at the location they require. People can just do online ordering. Some of you are already doing this. And this is the kind of product we're looking at. We have two partners here. We have Oral-B or Diplomat, and Colgate came on board with us and they were really excited to be part of this initiative. We have children's products and adults products. So the children's products will still have the over 1,000 parts per million of fluoride in them, but they just are packaged to be more attractive for children, and some of them might have slightly different flavors that aren't so stringent because kids don't always like the kind of adult, really sharp mint flavors. And we have we tried to make it really simple, so we have a small toothbrush and a big toothbrush, basically a children's one and an adult's one. So it might seem like it doesn't actually match the age group of the children you're working with, but we just went with one small one for kids and one small-headed but adult brush for anybody 7 and over. We're calling this a discovery year because we're not 100% sure, obviously that we're doing the right thing. It's never been done before, and we need to be able to respond if we discover that through our evaluation that we're running, that the product isn't getting to the right people and isn't being done in the right way. We have a Kaupapa Māori evaluation and a Pacifica evaluation running alongside. And since December, we've given out 250,000 units, so toothbrushes and toothpaste, and we're averaging about 70,000 units per month at the moment. The evaluation, just to give you a quick heads up, so it's a bit difficult. We don't expect the providers to give us exact numbers of, that family got, 10 brushes and that family got 7 brushes or that sort of thing. So we're relying on our distribution data for our evaluation. We are also relying on the New Zealand Health Survey information on toothbrushing. And over time, we hopefully will see a change in the levels of decay in the DMFT measure that we record all the time. It's really valuable for us to have the different methods of distribution and access and connection in the hope of improving equity. And we expect to see an interim evaluation report in around March 23 next year on that first year up to December 22, and then more final reports towards the end of next year that can help us with where we're going. So hopefully that has given you a bit of an idea of our oral health promotion initiative.
Riana, thank you very much for that presentation. I think it's really important to see that it's both happening and going to be evaluated, especially as many programs don't get evaluated. So it'll be nice to see what actually happens with all this effort. There's lots of questions coming up, especially around the public health area. So I can see that we'll be coming back to you for some questions at the end. But our third and last speaker today is Associate Professor Alison Meldrum, again from the University of Otago Dental School. She is head of the discipline of pediatric dentistry, and her main research interest includes childhood dental caries. And she's well known. When I was talking to Plunket recently, they said, "Oh, we've got to have her talk because she's so good with actual real children being seen in clinic and how she deals with it." But we did ask her to actually give us an update on recent developments in caries treatment, probably not prevention. So I'm looking forward to hearing what's new in this area. Alison, over to you. Can we see her?
Thank you, Barry. Good afternoon, everybody. I'm taking a slightly different approach, as Barry asked for a different approach, and And when this image comes up, I often wonder what you think when you see this image. When I see this image, I get a real buzz because what I see is clean white teeth and healthy gums. I don't see the eyes, I don't see the smile, but I love the smile. I just see those white teeth. I don't see a lot of that. What I tend to see is something more like this image. And I've used the quote from WHO that says that every child has a right to the best possible start in life, which paves the way for healthy development and lifelong learning, similar to what everybody else has said. Similar to what Barry said, that the mouth does actually reflect the rest of the body. Oral health affects everybody. It affects the way we smell. People who have bad breath are socially not very acceptable. The way we smile. Children are aware of smiling, and when they're losing teeth, it's fine. But if they're missing teeth for other reasons, or if they've got black discoloured teeth, that doesn't help. We speak, and Barry mentioned growing up knowing what toothache was like. A lot of our children still know what that's like, unfortunately, and the way we chew. If our teeth aren't healthy, when we chew, food gets caught in between them, and that can cause problems. What we know with the management of dental caries is that pediatric dentistry and special care dentistry, the children and the adolescents need time to be able to adapt to the clinic. So we want to have something that can actually stop or slow the progression of tooth decay, to give those children that time to acclimatise to the dental environment. We want to try and change behaviour, although changing behaviour is the hardest thing to do. We want to be able to affect diet and oral hygiene like the new programs are going to do. And maybe we've got methods that we can prevent pain and infection until the tooth actually leaves the mouth, exfoliators. Is there anything available? There's something called silver diamond fluoride. Unfortunately, it's not available in New Zealand at the moment, and it's been around for a number of years. It's an odorless, colourless solution with silver fluoride and ammonium ions. It's got a really high concentration of fluoride ions in it. And the antimicrobial effect actually works against the bacteria that cause dental caries. And it also plugs the dentinal tubules. The dentinal tubules are the part of the tooth that's exposed when tooth tissue is lost through dental decay. And it inhibits collagen degeneration, which means that it stops the progress and by creating a physical and decreases the permeability of the tooth. Also acts as a reservoir of phosphate and calcium fluoride ions. Really important if we have those in the saliva. And the fluoride, as Riana has already said, it helps remineralize that demineralized or broken down tooth tissue. So silver diamond fluoride allows stabilization of caries. It can allow the restoration treatment to be deferred or even put off forever. And it might mean that the children get adapted into the clinical environment so they can receive such treatment without sedation or general anesthesia. It also is another armamentarium into be able to manage symptomatic molar hypocysa and mineralization. That's something that happens in the teeth. The first permanent molars that come into the mouth at about 6 sometimes come in with defects on them. And these defects are called hypomineralization. And once they come into the mouth, the teeth tend to break down and we get caries as a result of this. And these teeth are really painful to manage and cause children a lot of stress. Silver diamond fluoride can often prevent that breakdown and stop it until we can manage in a different environment. It's less expensive and it doesn't require costly materials and equipment. It's regulated in the United States, in Australia, and the UK. In the United States, it's also regulated for approval as one-off management of dental caries. It's usually used for dental hypersensitivity. Registered medicine in Canada. We have no approval from MedStafe at the moment. The manufacturing companies and the supply companies have tried to get approval, and the quote was, it's expensive and it's a frustratingly long, arduous exercise. Its absence is certainly limiting the ability of clinicians to be able to provide care, and it's got proven efficacy in the management of dental caries. It's applied simply. You don't need equipment. You can use cotton rolls, and you can see here there's a tooth at the lower bottom right that's all broken down. You put cotton rolls in it, making sure that you isolate from the tissues because it can burn the tissues, and you use a circular motion. Some of the suppliers say for 3 minutes. 3 minutes is almost impossible to do in a child, and particularly in a non-clinical environment. So you use a little micro brush, which is like a little wee tiny brush. You circulate it around the tooth, and you make sure you cover all part of the tooth that isn't decarious. Then you blot it dry, and you leave it, and you ask the children not to eat or drink for 30 minutes. You have to have precautions. You have to have informed consent. It does have a particular metallic taste. It has a black appearance, and you can see the black appearance in this image here, around there on that tooth. This is a tooth that has got hypomineralization. It does have the potential to stain clothing and clinical work softs, so you need to make sure you take care with that. I've mentioned the need to avoid soft tissue connection. If it happens, if you touch the soft tissues, you have to wash the tissues and dry it, and often you get this black lesion that appears there for 2, but that will resolve in 2 days. The effectiveness of it. There's a lot of research that shows that it's really effective. It has reduced caries and the development of new caries lesions. So it's not only stopping them, it's stopping the development of new caries lesions. Using it biannually has certainly showed a significant arrest in caries lesions. These have been in studies in China, rural China, and in Brazil. There's been no adverse systemic effect of or serious side effects as a topical medicament, which is a real plus. The minor adverse reactions are tooth and gum pain, which often would happen, soft tissue swelling and bleaching if you've dropped it on the soft tissues. It does stain black, and the parental response varies to the black staining. Here's an example that this, you can't see it, but these top teeth have got active decay on them. The tooth is soft and mushy. Down the bottom, the teeth have been 12 months after sodium diamond fluoride was placed on these teeth in a rural environment. You can see that it's actually stopped that decay. I'm sorry, I'm having trouble with this thing. Here, it's a recent study that was done in collaboration with the University of Otago in Papua New Guinea, and it was comparing different types of material, but the baseline of 52 children aged 2 to 5, they had application of silver diamond fluoride in the environment. And you can see it here being put in the environment, how it was worked. This is in a church village, and you've got someone head to knee application. The parent is looking and applying the silver diamond fluoride. A retention rate of nearly 85% was fantastic over 12 months. And what they found that, and perhaps in Papua New Guinea, it's not so important because a lot of the children unfortunately chew betel nut, so they have stained teeth anyway. So that wasn't a concern. And the older children found the taste more acceptable. So not the 2 and 3 year olds, but the 5-year-olds. And it's a really effective public health message. And the comments were made earlier by Jonathan saying that teeth are being extracted rather than restored because there's often delays in children getting to general anaesthesia. If we could use this material, we could prevent and halt the decay and then restore the teeth at a later stage, either under general anaesthesia or perhaps the child has got used to the dental environment. In 2002, a number of faculty members wrote a letter to MedStaff. And it sums up exactly what we're trying to say, is that there is that issue of children presenting with severe early childhood caries requiring specialist treatment. There's a real unmet need, and silver diamond fluoride can certainly help affect this clinical need. And it will affect all those groups that we talked about, the low socioeconomic group, the Pacific group, the low income, and also it will be of benefit to our older population if we can get it in. And there's a number of references Thank you.
Alison, thank you very much for that very interesting presentation. It's a treatment that I was unfamiliar with until very recently. And I guess education of other health professionals may help with some of the pressure that might need to be put on Pharmac with regard to this. We're going to, I'm moving over, I think, to Paul Watson now, who is going to manage the question and answer session that we'll now have for 15 minutes. Paul.
Kia ora koutou. Thanks, Barry. Ko Paul Watson taka whenua, no Otatahi hau. I work for Āwhina Plunket. It's my pleasure to sort of thank the panels of speakers today for their thoughts, and also to just make a couple of comments. I guess we've heard a lot about the statistics and the evidence. I just want to touch briefly too on the lived experience for the children and the families experiencing early childhood caries, and the pain and the lack of sleep and the impact that has on families and functioning. So we know how important sleep is for families and children, and how distressing that can be for families. So I think behind the statistics is also real families experiencing pain and suffering, and I think it's a place to sort of keep that in mind. And the other sort of comment I wanted to make, I guess, is that, you know, we often say it takes a village to raise a child. I think this is also a problem that's going to take a village to address, and you know, we've got 114 people on here today as part of the village that can actually help address this problem. And also just to point to the importance of family and whānau in addressing this thing, this issue, and that it's important for the whole, to look at the whole family. So to thank Jonathan for his talk and the focus on epidemiology, sort of highlighting, I guess, the improvements that have been made over the longer term, but you know, things have stabilized and not improved much over the recent time, and that large ethnic gap that we have, the socioeconomic issues and inequalities in treatment are important things for us to note. And thank Riana too for talking about the initiative, Ministry of Health Te Wharaora, and making the toothbrushes and toothpaste and educational resources and things available, and I guess targeting those at the very populations that Jonathan started suggested important. And so to thank, sorry, I said Alison instead of Riana, apologies, I think, and to thank Alison for informing us about the silver damning fluoride and its potential to really make a difference to young children in treatment in New Zealand. So perhaps, I know there was a question there that perhaps Jonathan might like to answer. There was a question, Jonathan, around the ethnic disparity data that you presented, and whether that was in a particular location in New Zealand or spread over the whole country.
It's mixed fluoridation status of the region, and we didn't have fluoridation data on that one. And so I hope that answers that. Mixed fluoridation status in that region.
I think there was a question about what region was it?
Auckland region. Yeah.
Yeah, thank you. And there was a question around the amount of toothpaste for the different age groups, and whether someone referred to the P size, and whether it was the same for all children under 5 or different amounts. I don't know, Riana, whether you want to comment on that.
Yeah, to make it very simple, it's just a half pea sized for under 5s, and then anybody over that can be the full pea size. As I say, we used to say smear, and we had to drop that word. And I think probably a half pea sized is a little bit more scientific than a smear anyway.
Thank you, Riana.
Paul, can I just take a question to you? Because one of the questions was, who's responsible for educating new parents about this? I thought you should take that.
Thanks, Barry. Yeah, I think I go back to my argument that, it's going to take a village. I think we all have a responsibility there, and certainly child tamariki or providers have an important role in terms of working with parents to help them understand the importance of oral health and the things that they can do to improve that and the way they can role model that. So I think, child tamariki or providers have an important role there. But so do practice nurses, so do general practice, so do people in working in anywhere in child health settings. I used to work in the Children's Acute Assessment Centre at Christchurch Hospital, and we did some work looking at children that had general anaesthetics to have their teeth removed, and almost, I can't remember the percentage now because it was a while ago, but a high proportion of those children had multiple admissions to hospital prior to that for other general health things. And often we look in people's throats past their teeth. Like, everyone has an opportunity. I think we all have to play our role in working with families and communities in a sort of opportunistic way.
Can I just one more, and that's to pull together a series of questions that are more public healthy. Several have commented on the importance of the food environment. There's a question about whether sugar politics is important here, because I think we all would understand that water and milk are the main recommended drinks for children, but I think the whole thing around, I might go to Riana and say, where are we with the politics at the moment around sugar containing drinks, etc.?
So recently the Ministry of Education actually had a consultation about whether or not they should mandate water and milk only at schools, and we're waiting for the final result of that. But I am getting the impression that certainly they are going to be working very hard on having water and milk only at primary school and working their way up towards introducing it at high schools, from what I gather. So that will be really helpful to have that starting in schools at the very least.
And just move, Jonathan, from the public health point of view, anything about the food environment from your point of view?
It's the food environment upon which all of this is based. So, if a person has an optimal, healthy diet without too much carbohydrates, then Caries rates can be low, even effectively eliminated. However, I don't think we're going to see the elimination of food products like bread. Bread is cariogenic. Everyone needs to brush their teeth twice a day, no matter what. Anything to add to that, Alison, Riana?
Yes, I think it's the strategic way that food is marketed in a supermarket has a huge bearing on it. You get to the end of the aisle and there are all these cariogenic, horrendous foods, both for teeth and for body shape, sitting there. You're waiting, your children are tired, end of the lot, you give in. Sugar sweetened beverages are much cheaper than milk and bottled water. Yeah, it just seems that we've got it all wrong.
Yeah, I know. I've got 4 little kids of my own, and it's frustrating when you go to a shop and just because your child was good, or maybe because they weren't good, they're handed a lollipop, and so I am the bad parent who then has to be the one to take that away from them. I don't like that. So I'd like to see lollipops and things like that denormalized, and the the food at child eye level, the lollies denormalized.
Agree 100%.
Another question for Riana, perhaps. Is it, as our toothbrushes and toothpaste going to be reintroduced for the 4-year-old check, or introduced for the first time?
So what I would say is, if you're seeing a family who you can see needs product, I wouldn't say there's any reason to hold back from giving them product, really. What we're trying to do, though, is because we've only just really started this initiative, is we're trying to make sure that the supply and demand match, because we were kind of guessing numbers. Now, it looks like our numbers are pretty on target, but we're just a bit worried if we go too far, too fast, we will run out of product. So as I say, if you see a family who desperately needs product, I wouldn't hold back from giving it to them. But, you know, we're working our way towards having product going out at all the checks. Yes, that will be a plan.
There's another question there that perhaps Alison or Riana might like to answer about. Is it okay to use Colgate that says 6 years plus for under 5s?
Yeah, yes. One of the problems we have is that the toothpaste, etc., they're not developed specifically for the New Zealand market, and they have a different recommendation over there. In fact, they still have those low fluoride toothpastes in Australia and still recommend them for younger children, which we don't have, partly because they have much higher rates of water fluoridation there than we do. So absolutely, if it says 6 years or whatever, it's absolutely fine. But as we've said, children have to be supervised while they're toothbrushing until about, say, 7 or 8, and ideally have the teeth brushed for them until they're about 5 and can maybe hold a pen or tie a pair of shoelaces or something. So just being careful they're not swallowing lots of toothpaste. Sorry, Alison, you were going to say something.
I agree 100%, and you've answered the way I have. We had lots of arguments with our Australian colleagues because they were recommending and we didn't want it. And because it's not manufactured here, we have to go by their packaging.
That's right. Yeah.
Pat Tui's asked a couple of questions. Thank you for joining us, Pat. Seeing he was heavily involved in this in previous years. The question is, I think, to Jonathan, if the DMFT rate are decreasing, why is the extraction rate under GA going up?
Well, it's that tyranny of averages and children waiting to be seen. Also, as decay rates come down, you know, looking at our data from, for example, the Dunedin Multidisciplinary Health and Development Study, there are study members there with very high rates of tooth decay, sort of things that match the levels you might have seen in the 1950s or the 1930s. There are people left behind. It's those people who are being seen, and if they're being seen late, or depending on how it's being managed in the in those clinical services, there can be wait lists to be seen, and that can be a challenge, ending up having to remove teeth.
I see a question from David Barker asking us whether, this is probably a ministry, at least a Riana question, are there any metrics around equitable matching of paediatric dental workforce to the distributed child population? Have we, or is everybody focused on the low risk groups, I guess is the question. Is there an equity in the health workforce distribution?
So we have some challenges in the workforce at the moment within the public service. We have a number of vacancies across the country for oral health therapists, dental therapists. And so there is some work going on in Te Whatu Ora in the workforce task force. There's a lot of forces in there. But there is some work going on in that space because we are short of therapists for this work. We also have had some issues post-COVID because a lot of our community oral health services either had to stop working for periods of time because of lockdowns or because of increased infection prevention and control measures as a result of COVID and the circulating viruses. The kind of number of kids that can be put through in a day is reduced. And so there are some backlogs around the country, some areas obviously like Auckland, Waikato, who had more lockdowns, and Northland probably worse than others. And so the short answer is there is a bit of a challenge at the moment with workforce, but there is work going into that. The DHBs, as they were, the oral health services around the country, are focusing as much as possible on seeing the high-risk kids more so that they're targeting the high-risk kids first, beyond the other kids where they can.
And I could add as well, workforce rates for oral health therapists. You could find some information in workforce reports of the Dental Council of New Zealand.
There are a few other questions, but Paul, I think our time is probably up, and whether you might want to wrap up, and we'll try and answer the other questions as time goes with when on the website, when the thing's published on the website.
Sure, Barry, thank you. So just want to thank panelists once again for their contributions today, and for everyone that's been with us online for sharing your questions and your knowledge in the chat. Thank you for that. And thank you to the Better Start Challenge for organising the webinar for us.
Ka wai e te whānau. Oh, well, that's wonderful. Thank you so much for all of your kōrero, your research, your whakaaro, and yeah, we'll looking forward to the next webinar. Nā reire runga i tērā, ka kapia ki e tā tātou hui. Unuhia, unuhia, unuhia te urutapu nui, kia wātea, kia māma, te huarahi i te arataka tū, ko ia rai runga whakairia ki runga kia tīna haumi hui e tai ki e. Thank you again to our speakers and to all our audience members. And again, this will be on our socials and websites for further viewing and to share with your colleagues, etc.